Good afternoon, everyone, and welcome to the webinar, Policy Approaches to Reducing Health Inequalities, offered by the National Collaborating Center for Healthy Public Policy, or the NCCHPP. On technical note, please use your computer speakers or dial into the teleconference number using the information that is on the screen. Also note that we will be using the chat box throughout the webinar for questions and comments, so feel free to post them throughout, and we'll get to as many as we can during the question time pauses that we have planned for the webinar. You can also use the chat box to reach us if you're experiencing any technical problems. And do please note that the webinar, including the conversation in the chat box, is being recorded and will be available on our website in the near future. Let me introduce the NCCHPP team for today's webinar. I am Val Morrison, and I will be presenting the material today. Also joining us is Mylène Magloire. Mylène has put together all of the logistical details for the webinar, including the planning, registration, and evaluation. And she's also responsible for technical support during the webinar. Thank you and welcome, Mylène. Also with us today is Michael Keeling. Mike will be facilitating the chat box and helping with questions and comments. And since there are more than 350 people registered for the webinar today, I'm sure that will keep Mike busy, but we won't be opening the phone line, so we will be using the chat box throughout, so please feel free to post comments or questions, and as I said earlier, we will get to them, as many of them as we can when we take pauses to do that. Since today's webinar is accredited for continuing education, I'm obliged to inform you that I have no real or potential conflict of interest related to the material being presented today. And in line with the accreditation, if you are a doctor and want to get credit for this event, you will need to fill out the evaluation form and provide all of the information that is requested. The evaluation will be sent by email shortly after the webinar. Let me now briefly introduce our center. The National Collaborating Center for Healthy Public Policy is part of a network of 6 National Collaborating Centers for Public Health across the country and financed by the Public Health Agency of Canada. Our offices are located in Montreal and Quebec, and I'll take this opportunity to ask you to indicate to us on the survey that Mylène has just put up where you are at this moment, where you're joining us from. So we can see your answers in real time. So quite a few of you in Ontario, also Alberta, spread across Ontario, some in Nova Scotia as well. International, can you go down on that? Okay, so throughout the country, but a fair amount of you in Ontario and also Alberta, but the rest of the country also represented. So welcome again, everyone. I will continue to talk just a little bit about the NCCHPP specifically. Our mandate at the NCCHPP is that we support local and regional public health actors in their efforts to promote healthy public policy, by which I mean policies from outside of the health sector that favor population health. So these could be fiscal and labor policies or policies in areas like housing and the built environment. We are also concerned with how policies affect health in generating and using knowledge about policy and policy making. Before we dig in to today's material, The webinar is based on a document that we recently published called, not surprisingly, Policy Approaches to Reducing Health Inequalities. This document is co-authored by myself and my colleague Pascal Mantoura. The long form of the document is available on our website, and we have started to produce shorter documents breaking down this longer one. The first of these, on the difference between the social determinants of health and the social determinants of health inequalities, will be published shortly. A quick word about some of the terms that we're using. Firstly, when we talk about policy approaches, we're using that quite broadly to mean the general orientation towards an issue and the types of policies that are most often proposed from that perspective. So some of the approaches, say political economy, Lifecourse, or intersectionality, have large and developed bodies of literature that are fairly coherent and explicit in their approach to policy. Others, approaches that focus on individuals or macro-social policy, for example, are much more varied, and their theoretical baggage is often implicit. And our job was to tease out the commonalities, and some of that is what we're presenting today. The second term that I want to say a few words about is health inequalities. Most of you know that other terms are sometimes used, health disparities, health inequities. Notably, our choice to use health inequalities is mostly a practical one. The WHA, for example, uses inequity in English, but inégalité, or inequalities, in French. And since we publish in both languages, we simplify the lack of agreement about the term, especially in French, where both inequity and iniquity are translated as iniquité, or iniquity. And with a few exceptions, in our documents, we use inequalities in both languages. But for all intents and purposes, our way of viewing inequalities is in keeping with the term inequities as it is generally used in English. So our objectives, kind of outlined for today's material, is firstly to understand the difference between the social determinants of health and the social determinants of health inequalities. We're mainly using the WHO's Commission on the Social Determinants of Health and supporting documents, and we want to insist that this distinction is a crucial one. We'll also introduce and differentiate between 8 policy approaches to reducing health inequalities. We'll concentrate mostly today on 3 of those. And finally, we'll talk about the practical implications of using these approaches and how they link up with that difference between the social determinants of health and the social determinants of health inequalities. The definition of health inequalities that we're using comes from the Chief Medical Officer of Health report in 2008. That is the difference in health status experienced by various individuals or groups in society. These can be the result of genetic and biological factors, choices made or by chance, but often they're because of unequal access to key factors that influence health, like income, education, employment, and social supports. So this is a fairly broad definition that allows for differences due to genetic and biological factors, choices, and chance, but also and often an unequal access to factors that influence health. So those listed there: income, education, employment, and social supports. Pascal and I, and perhaps many of you, became interested and even sometimes frustrated with, on the one hand, the increasing call for action on the social determinants of health, and more recently on health inequalities, and the seeming contradictions between that and actual policies, both those directly related to public health and those in other areas, where we see contradictions like adopting anti-poverty measures on the one hand and deregulating markets or making deep cuts to the social safety net on the other. And within public health, the unusual tendency to acknowledge the need for acting upstream or on what some call the structural determinants of health, but adopting programs that focus mainly on individual behaviors and factors. Some refer to these as the holy trinity of smoking, diet, and exercise. And the term lifestyle drift has more recently been used to discuss this tendency of recognizing the need on the one hand for structural determinants of health, but developing interventions and policies that target individual and behavioral determinants. So we wanted to take a step back and try to tease out what this means in terms of reducing health inequalities. And that also meant teasing out how health inequalities are understood and how this ends up meaning policy and program interventions are focused. In 2004, Hilary Graham wrote of how we tend to conceive of and act upon health inequalities in three different ways. One in terms of disadvantage, in terms of gaps, or in terms of the entire health gradient. So I'm just going to put up a couple of examples, graphic examples of these different ways of conceiving of health inequalities in Canada and how we can see them illustrate these three different ways of conceiving of health inequalities. So this one looks at asthma burden by Aboriginal status in Ontario. And so we see there that we are measuring inequalities in terms of a gap between Aboriginal population and non-Aboriginal population, and focusing in that way on a disadvantaged population, in this case, Aboriginal peoples, in terms of asthma. In the second example, where we see hospitalization rates for heart attacks in the population of Canada, again, we are focusing on a gap on the one hand and the entire gradient in this one. So we see the gap, especially on the bottom of the chart, where we're comparing all quintiles with the first and the fifth quintile, so comparison between those with the highest income and those with the lowest income, and then either of those to the average. And on the graph itself, we see all five quintiles represented there. So in that way, they're showing us the entire gradient as it is measured by socioeconomic status. And then finally, as an illustration, we see life expectancy at birth by neighborhood income and by sex in urban Canada. And this, again, shows us the gradient, the socioeconomic gradient from quintile 1 to quintile 5, or quintile 5 to quintile 1 as it is, as well as a gap, often less talked about in these documents, but the gap that exists between males and females. So Graham suggested, as have many others, that in order to have an appreciable effect on health inequalities, we need to address them across the gradient and work towards leveling that gradient or flattening out those differences between different groups. Okay, so I'm going to ask a quick question, a survey question that Mylène will put up again before we start to look more in depth at the policy approaches. So it's kind of a just a quick off the top of your head sort of question about what you think the single most important thing to focus on to reduce health inequalities in Canada would be. So just to get a sense of what you think of these. And note that all three that are there have either existed or been proposed, either here in Canada or elsewhere. it looks like there's a fairly strong tendency there. We did this webinar last week in French, and I was a little surprised. Maybe I'm not as surprised this week because I anticipated that it would be very similar, so that most of you think, in fact, that the single thing, if we had to choose just one, to focus on to reduce health inequalities in Canada would be in the area of a guaranteed annual income. So you're upwards of 95% of you voted that. There is no intended right or wrong answer here, but we can come back and talk about that. What I just wanted to mention is that in asking this question, there's obviously an underlying question that I could have asked that might be formulated as what explains health inequalities. So in terms of those examples, is it having a disadvantaged start in life? Is it access to material conditions such as adequate food? Or is it unequal wealth distribution that means that too many people find themselves without adequate resources? And all of these things undoubtedly affect the distribution of health throughout a population, but they have kind of different points of entry on what I will call a continuum of determinants of health, and I'll explain what I mean by that a little later on. Many of you will recognize this graphic or conceptual framework from the WHO's Commission on the Social Determinants of Health. This is from the conceptual framework itself that was published after the report in 2010. But if we think about where your answers fell a minute ago on that question in terms of reducing health inequalities, you can see that they fall on the far left side of this in terms of social public policies and perhaps macroeconomic policies as well, but definitely in that socioeconomic and political context box. Okay, so this difference here between the social, on the left it says structural determinants, but social determinants of health inequities, and the intermediary determinants or the social determinants of health on the right is the one that we really want to focus on, because it's one that often gets a little bit lost or muddied, and that may in fact be crucial. It's important that the conceptual framework puts them in separate boxes. They are related, but they're not the same thing. And in order to work on health inequalities or health inequities, we need to work on the social determinants of health inequalities, which are in a sense what determines the social determinants of health. And that isn't to say that the social determinants of health don't feed back into the determinants of health inequalities. They do. Those policies and values and ideologies and norms and systems of governance tend to favor some groups, and that favors reproducing the underlying social determinants of health inequalities. So going back to what we were discussing earlier and the need to focus on the entire gradient, we want to reiterate that reducing health inequalities also requires focusing on the social determinants of health inequalities that underlie both the determinants of health and health inequalities. This graphic that we produced is a kind of a pared down version of the WHO's conceptual framework, where we see the sort of flow of the determinants, or what I was calling the continuum a few minutes ago. We're going to come back to this and plot policy approaches on it a bit later, but you can see that it keeps the social determinants of health and the social determinants of health inequalities separate, and with the former being largely shaped by the latter. So the 8 policy approaches that we looked at with this work and that we discuss in the document are political economy, intersectionality, macro-social policies, Lifecourse approach, and approaches that focus on living conditions, settings, communities, and individuals. And this list isn't meant to be necessarily an exhaustive one. There may be ones that we've missed, but I think we cover the main ones that we see used and propose to be used to reduce health inequalities. As I said earlier, not all approaches to reducing health inequalities are explicit in their approach or in the underlying theory, epistemology, or methodology that they use, but we can tease out some commonalities in how they tend to answer a few key questions. So these are the key questions that Pascal and I asked of each of the approaches. And the first is, how is inequality conceived of? So if inequality is seen as the result of individual achievement or merit, that will tend to affect the types of policies that are proposed, as will viewing inequality as the result of income distribution or the access to power and privilege. And the second question that we asked is, how does the approach explain health inequalities specifically? It's related to the first one, but not always directly. So, for example, we see higher rates of smoking in low-income groups. But if our question is, how do we get people in low-income groups to quit smoking, that is quite different from how do we reduce poverty, or how do we attempt to account for the fact that the majority of people in low-income groups are in fact non-smokers. And then the third key question that we ask is, what does the approach focus on? In other words, what types of policies are generally proposed from each of these perspectives? And then finally, we try to look at some of the strengths and limitations of each of the approach. And some of you who've looked at it, or maybe will look at it after, you'll see that we attempt to present this information in a kind of table form to make it a little bit easier to access, or at least easier on the eyes. But since we only have an hour today, we won't go through all 8 of them, but please do consult the document on our website on your own for more detail. But we'll focus on 3 of the approaches, so political economy, Lifecourse, and approaches with focus on individuals. So if we look at these 3 approaches in terms of the key questions that I was just talking about, and start with political economy, in terms of how inequality is conceived of and how health inequalities are defined, from this perspective, inequality is the result of macro policies on wealth distribution, financial market regulation, labor law, etc. And inequality is a characteristic of society, not simply of a difference between individuals. And health inequalities, from this perspective, are the inevitable outcome of social inequality that has its roots in the political and economic distribution of power. In the second case, the Lifecourse approach that we'll look at, inequality is imprinted in the Lifecourse and is the result of interactions throughout life between individuals, their choices, and their ability to act, and social structures and the sources of inequality. Health inequalities, from this perspective, result from variations in the sets of factors that protect health or put it at risk that one is exposed to throughout the life. And then finally, approaches that focus on individuals view health inequalities as the result of individual choices and characteristics. And the poor health of some groups is exacerbated by modifiable behavioral risk factors which stem from personality traits or from personal deficiencies, sometimes from a lack of knowledge or education, or individual cognitive limitations, etc. So we reached our first pause for questions or comments. So I'm going to ask Mike that he look through and see if there's anything we want to raise.
Thanks, Val. There are 2 or 3 questions that have come up during the course of your the last 5 minutes or so.
Okay.
One, I think it would be important because of a discussion thread that's been going on. Could you just reiterate what you said about the choice of the word inequalities as opposed to inequities? There's been a bit of discussion about what was the rationale behind that. Maybe you could go over that again.
Sure. It's one that comes up often for us and one that we sometimes go back and revisit. As I said, it's a fairly specific choice based on practicality in the way that we use inequalities. And it's one of language between French and English because the language in French, it's more common to use inequalities. There are a few people who use what would probably be the equivalent of inequities, but the word inequity doesn't exist in French. The word is the equivalent of the English iniquity, so the word is iniquité, which of course in English, iniquity and inequity are not quite the same thing, and there's fairly important moral dimension or distinction between them. So it's really a practical implications. We do have some documents where we use inequities and then we explain it in that context, but as I said earlier, it's not a perfect solution, definitely, but we do it for practical reasons, but do use it not quite synonymously, but in the way that inequities are used in many publications.
Okay, and Lorraine asked for a little bit more information about what the model is called. Solar and Irwin 2008 came up in an earlier slide. Could you maybe just refer to the original document?
Yeah, that is the conceptual framework of the WHO Commission on the Social Determinants of Health. Sorry, I'm having to go back quite a ways here. The one that was in the final report in 2008, they kind of simplified it down a little bit. I think they took out the social cohesion and social capital there. But when they published along with, as I'm sure most of you know, along with the main report, Closing the Gap in a Generation, they published several conceptual frameworks along the way. And this one went back through all of that work and tried to make more explicit the conceptual framework that was behind the final report. The final isn't that much different from this. It is a different color. It uses kind of orange that fades into, or red that fades into orange and yellow, but the boxes are still separate. I hope that answers the question.
Here's a bit of a tricky one from earlier on. What are the potential sources of lifestyle drift?
The potential sources? Oh, there are a lot of them. Some of them are as practical as us using health inequalities. They're a result of the mandates that different health actors in different organizations and at different levels have. That it's sometimes easier to get funding for or to get people behind interventions that focus on lifestyle. And I suppose the broader questioning of the types of political and governance organizations that we have is seen as prohibitive. And so we see this drift towards something that can and does work in some ways. And I think most people acknowledge that programs like that can have significant benefits. And what we're saying in this document is, yes, they can, but they can't reduce health inequalities or are very unlikely to in and of themselves.
Okay. You want to continue? I think
yeah,
we should keep an eye on the clock.
Yeah, we'll keep it going, and then hopefully at the end we've got another question period and some time. So if there are any that are left there, maybe we can come come back to them. Okay, so I'm going to move on now to kind of exercise, insofar as an exercise can be done in a webinar, but to sort of see how we can use some of these ideas in practice. And I think we can do this in two main ways. One would be to start with existing policies or programs, and try to understand their potential impact on reducing health inequalities based on the policy approach that they seem to take. Okay, so that's sort of starting with the policies of the programs and saying, okay, well, what kind of approach is this, and what does that mean in practical terms? Or we can try to imagine policies or other types of interventions by starting with the approaches themselves, which is what we'll try to do now by taking the example of food insecurity in Canada and see how these three approaches that we're limiting ourselves to today might work. So again, I'm using this example of food insecurity as illustration, sort of, without looking in depth at the issue of food insecurity itself. But we do know, most of us, I think, that work in this field that know that food insecurity has become more important, both in terms of its existence, that is that there's more and more food insecurity, but also that it's received more and more attention, deservedly so. So we see food insecurity, this is already about 5 years old, but we see a growth in food insecurity in Canada over the previous 5-year period. Or we can also look at some headlines from popular press or research reports talking about food insecurity, different groups that are food insecure, and how high fresh, especially fresh produce prices are affecting food insecurity. So what we want to do then is see if we can design policies to tackle this issue. So if I put up a kind of hypothetical position for you to put yourselves in as public health actors who are asked to design policy alternatives to tackle food insecurity in your area, in your health region, or at whatever level you work, and what you think these might look like from each of the three approaches that we're concentrating on today. Okay, so what we want to focus on is the approaches, and try to see how the way that inequality and health inequalities are defined, and the focus of the approach would determine the types of policies that are likely to be proposed. Okay, so what I'm asking of you is not to worry too much about the specifics of a policy, but ideas for policies like the ones that I put in the earlier survey about the one most important thing you could do to reduce health inequalities, but specifically here on food insecurity, just to write from each of these approaches one or two ideas that you think might come out of these approaches. What I'll do while you're thinking and while you're writing about that is that I'll go over the three approaches again to remind us of their focus. And you can go ahead and write them in the chat box, and as we get to the end of the exercise, again, we'll ask Mike to read some of them out. So as I go through this, feel free to jot down some of your ideas in the chat box. Especially using, as I've just said, the first three questions in the table that I showed you before. So how is inequality conceived of? How are health inequalities explained, and what's the focus of the approach? Using that as a guidance for your policy suggestion. So from the individual approach, again, these tend to target individual actions and choices. Poor health, from this perspective, is exacerbated by modifiable behavioral risk factors. the approaches are often ones that encourage individuals to, quote unquote, make healthy choices. And they tend to focus on strengthening those who are most vulnerable to modify their behavior. From the Lifecourse approach perspective, again, inequality is something that is imprinted in the Lifecourse and particularly focuses on moments of vulnerability during the Lifecourse and variations in the sets of factors that protect health or put health at risk. And the Lifecourse approach tends to target social circumstances and provide support during transitions and shocks throughout life. And then the third, the political economy approach, views inequality as the result of macro policies on wealth distribution and is characteristic of society rather than individuals, as I said before. And health inequalities are the inevitable outcome of this social inequality. The main focus is on macro or structural policies. So again, we're just covering these three approaches, but it's a worthwhile exercise to try and do this with all 8 of them as something that you might want to do as you read them and think of examples of the other 5 that we cover in the document. So just giving you a few minutes there, I suspect that we've probably got a few answers from individual and Lifecourse perspective, and maybe political economy is starting to trickle in.
Getting there, yep. I'm just taking some notes. What have we got? In individual, healthy eating campaign, recipes for healthy eating on a low budget. I wasn't sure if this one was intended to be individual or Lifecourse, but community kitchen. I think different conceptions of that.
Yeah.
It could be in either.
Probably,
Depends how it's done. I saw community garden. That one was, I wasn't sure if that was in Lifecourse or individual.
Okay,
Again,
yeah.
it really would depend on how it was done. Soup kitchen. More clearly identified as being in Lifecourse approach, I saw income support. And in political economy, an early comment, all people have sufficient income so that they can get what they need in terms of healthy food.
Okay, good.
And a few have been coming up since I started talking as well.
If you
Guaranteed minimum basic income
Okay.
from Nova Scotia Department of Health and Wellness. Lifecourse approach, working with building property management to create supportive environments for healthy eating for occupants, healthy food options, and so on.
Okay, well that sounds like a fairly
Individual cooking courses, Lifecourse, pregnancy support, political economy, basic income. That's from one. And that's from Raymond.
Sounds like a pretty good...
a few more coming in. Yeah.
Okay, we'll keep, if there's any other, we'll come back.